Well, good morning, everyone. Welcome back to day 2 of AP Valves and Structural Heart. It's great to see all of you here, and I think we have a hopefully another very educational, entertaining, and enjoyable day for everyone here. So I am David Cohen. I'm from the Cardiovascular Research Foundation and St. Francis Hospital in New York. My co-moderator is Jung-Sun Kim from Severance Hospital here in Seoul. The panel includes Paul Chiam, Joo-Yong Hahn, Shunsuke Kubo, Simon Lam, Takashi, Matsumoto, Hoon Park, and Shih-Hsien. And we are going to be joining the group from Cedars-Sinai, led by Raj Makkar, for 2 live cases, and I have no idea what they're going to be. So if Dr. Makkar is ready, there he is. Hi, Raj. Good morning.
Hi, David. Hello, everyone. Can you hear us?
Yes, we hear you just fine. My co-moderator here is Jung-Sun Kim here from Korea, and it's wonderful for you to join us late in your afternoon. In Los Angeles, you're missing a wonderful typhoon here.
It's already gone.
Yeah, and why don't you go ahead and introduce your team and tell us what you're going to be doing.
Okay, terrific. So we'll get started with this case, and it's a mitral case, but let me go ahead and introduce our team. To my left is Toon, who's my young associate. To my right is Josiah, who's one of our interventional fellows. We have Nicolette, who works for Edwards. Then Moody is at the North Pole there. He's going to be doing the imaging. You see him there.
Yep.
He's a master imager and will guide us through the imaging for this procedure. We also have Yassine, and we have Kylene in the control room. We have Kelly, also circulating, and then we have Kelsey. So, all right. So we are all excited to go ahead and present this case. So Josiah, let's go ahead and do so.
Yeah, perfect. So this is a case of a 77-year-old gentleman who has severe symptomatic mitral regurgitation due to posterior mitral valve prolapse with flail of the P2 leaflet, who comes in for transcatheter edge-to-edge repair. He notably has progressive exertional shortness of breath with NYHA class 3 symptoms. His past medical history includes DVT and bilateral pulmonary embolism in 2013, as well as a TIA in 2001. Additionally, has a history of hypertension and hyperlipidemia. Next slide, please. The echo here mostly just shows normal left ventricular function. I mostly want to take your attention to the right, where we have a baseline transmitral gradient, mean gradient of 3 millimeters of mercury. Next slide, please. Here you have 3D TE images showing the P2 flail. I think we'll skip these and go to the live TE images with Dr. Makkar. Our current plan for this case is to complete the edge-to-edge repair using the Pascal Precision system with the Pascal H device. We've already completed the transeptal puncture using the Baylis VersaCross system, which we can orient you to as well. And we plan our implants in the A2, P2 position.
Okay, terrific. All right, so I think what we'll do is, Moody, let's go ahead and if you can tell us.
Yeah, sure. So as you can see here, this is a 3D view of the valve here, and you can see it's in the surgical view, and there's a big prolapse and flail in the P2 area. And when we put the color on it, you can see it's leaking from both sides, the medial and lateral side. So it's a little bit wider jet than the normal variant. And you go to the 4th chamber view, you can see there's a big flail with a rupture port and an anterior directed jet. Then we're going to go to the BICOM LVT view. As you can see here, it's a very nice jet. It occupies the whole P2 part, localized to that. And we're going to go to the next slide here in the BICOM LVT. When we put the color here, you can see it's a mix of prolapse and flail in the posterior leaflet. We're going to go and check the baseline gradients for this valve. And the baseline mitral gradient was 2. And the valve area was about 10.5 centimeters. So it's a big valve here, as was measured using the NPR. And the hemodynamics were significant for having blunted systolic veins blunting in this view. So based on the criteria, we have a severe MR, we did the assessment baseline, and we did the transeptal, and it was at mid-fossa and as posterior as we can here using the VALVES system, as you see here. And we were able to get a height of 3.9, almost 4 centimeter, because the heart is very hyperdynamic.
Great.
Terrific. So thank you, Moody. So we use this VALVES system now in all our transeptals, almost all. So as you can see, this is the sheath, and the good thing about this is that you can actually shape it. So if you wanted to actually, you're having trouble getting in contact with the septum, you can actually give it a bigger curve. And then there is this wire that actually goes through it, which is this wire. So essentially what you're doing is you're using, electrical energy and then pushing it through. So you're looking at the fluoroscopy pictures. Are you able to see the fluoroscopy pictures?
There we go.
David?
Yep. Mm-hmm.
Yeah, okay. So I have to say, for me now, I think this is the safest way to do transeptals and the best way to actually teach transeptals to your trainees. And the other advantage is that this wire is strong enough. So you're not doing exchanges. You can actually put guide catheter over this wire. So whether it is an appendage occluder, whether it is the Abbott mitral clip, or whether it is the Edwards system, all of these catheters track nicely over this wire. And this wire is fairly atraumatic because of the way it is actually shaped.
Yeah, I have to agree with you. We converted over to using VersaCross in all of our transeptals about a year ago, and I wouldn't go back. It's the same.
Yes. Yeah. All right. So David, as you heard, that this patient is 77 years old. He's actually a retired physician. We, had him go see a surgeon as well, and he was not a bad surgical candidate. He was actually a good surgical candidate, and a lot of centers would actually send this patient for surgery. But we also offered him the possibility of getting into the randomized clinical trial. We are doing the primary study, which is randomizing patients to surgical mitral valve repair versus TEER procedure using any of these devices across all risk spectrums, whether it is low, intermediate, or high-risk patients. But this patient had made up his mind, and he just wanted to actually get a TEER procedure. So that's what we decided to do in this particular patient. Okay, so we've decided to use the Edwards precision system. So this is the guide catheter here. Through that is the steerable, and then this is the implant catheter, basically, which goes through the steerable. And all of these catheters can be moved independently. There is no keying like you actually do with the Abbott system. And there are pros and minuses. I think you can use this system, either one of these systems, for most of the procedures. And there was a slide that was there in the earlier, in the presentation. I don't know if that can be put back up again, but there is independent grasping with both of these, and you can see the available implant sizes, etc. So there is the ACE here, which is 6 millimeter wide, and then there is the Pascal, which is actually 10 millimeters wide. Those are the two devices that are available here. But I think the feature that I like the most is actually the fact that you can elongate this device. So if you're working in a commissure, and if you're entangled, you can elongate this device and you can actually come out without getting trapped. So that is something that I find very helpful. And also, you're not bringing a leaflet to the leaflet. There's actually a spacer in there. So you're bringing the leaflet to the spacer and leaflet to the spacer, which might actually have less tension on the leaflet and might be somewhat impactful in terms of having lower gradients. But I think some of those things we'll find out with time as we do more difficult cases.
Can you tell us a little bit about Raj, how you chose between the P10 and the ACE? That's something, we've only recently just started using this device, and I still struggle with it. If I were doing a mitral clip in this case, I would be using an XTW almost for sure. But how did you choose here?
So the XTW is 6 millimeter wide, and the ACE is 6 millimeter wide, and P10 is 10 millimeter wide. I found that it is easier to visualize ACE, and it is a very nice device. And I think I've become more facile because we all started off with P10, right, when we participated in the clinical trial, and the ACE was actually a latecomer. we know that we're going to use two devices here, and we thought 6 millimeter ACE and another 6 millimeter ACE should hopefully do the job without creating any significant gradients, as the valve is really large. So that was the reason. I just like using ACE. It's a lot more predictable compared to the P10, at least in my hands.
Great. Well, go ahead and get going.
All right. So, all right, fluoro, please. And Tarun, so feel free to talk and also, okay. So fluoro, okay, so we are coming out now. So we've actually, we've, huh? Yeah, you can. Yeah. Okay, so we are coming out with our system here, and what we will do is, as we come out, we close this. All right, we can rotate and adjust the orientation of the clasp or the clip. We use those terms interchangeably. So, and of course, we need to come back with the clasps here, right? Okay, and Nicolette, feel free to, okay. So you can see that the imaging that Moody is providing, we are flexing on this. Okay.
Too close to you.
Can you flip the images so that we see the echo the bigger? Are you guys able to?
All right, and Moody? Yeah. Okay, so we are lateral. We corrected our posterior position.
Raj, I think we can ask them to show fluoro and echo and take us off. So
That's good. That's good.
Okay.
that's right.
Yep.
Yeah? Okay, terrific. So we can come back a little bit. I think we'll come back with the whole thing because I think we can still, we want to come in the middle and maybe even a little medial.
It's,
This is when we're going to go to the BICOM LVOT view here.
Okay.
And then we're going to show the
great.
position.
Rajiv,
Okay, so
most
where
of-
are we?
yeah,
Why can't you see us? Are we?
Most likely you are on the, as you see here, you're a little bit in the
interior.
view here, you're a little bit in the anterior part.
Okay,
And the
let's
lateral
go
part.
ahead.
Then we're going to go ahead and do using the multi-view. Multi-view has been an excellent feature
we-
where we can do a live analysis
There we go.
to get all the views that we discussed here and to find the factors.
And there's a lot to look at. If we could see Raj's hands in a small frame, that would be great. Perfect. Yeah.
Okay.
Excellent. Perfect.
So I think that do we have a little lateral dive, it looks like?
So we have a little bit of aorta hugger here and a lateral
Okay,
dive.
so for the aorta hugger, we are going to actually go ahead and flex the guide a little bit, and that should stand it up. And we should go a little anterior here on the steerable. Right? Nicolette, you feel free to. Nicolette is the clinical specialist.
Yep.
And we always listen to them. All right. Okay. So I think, what do you think now, Moody? Do we?
It looks very, very good here. So
Okay.
looking at the medial to lateral, this is the BICOM view here. You can see it's nice in the middle. There's no diving. And looking at the LVOT view, we see almost perpendicular to the plane of the valve.
Yeah.
And we got rid of the aorta hugger very well. And we're in a good position here that we are just on the medial side of this lift.
Okay. All right. So.
So do you
think we
plan
need
to go
tighten the
go
M a
medial
little
first,
bit?
or which side are you going to put your first clip on?
We were thinking about medial first.
Yep. Great.
Yeah, so we started to divert a little bit, dive here a little bit more medial.
Yeah.
So you have a plan to clip?
To clasp.
Yeah,
Yes,
to clasp.
we plan to use two devices.
Yeah.
They like to call them implants. Okay, so we will use two ACE implants. Okay, if you guys agree, we are gonna open the device. Yeah.
Yeah, good.
Come back a little.
So you can see that we'll come back a little bit because we don't want to go down across the valve, and as you can see that we need to correct our orientation. So while I clock the device, I'm also giving a little bit of counterclock so that we don't end up, so we maintain our central position. So this
So this is one of
orientation
the-
is not bad.
Yeah, I mean, it's always one of the
Movie-
nicest things
Yeah.
about this device is how smoothly you can reorient it. It's much easier than with the
We have a little bit of a
mitral
medial
clip.
dive.
Looks beautiful.
Okay.
Yeah.
Yeah, Tarun
So-
is a
we may have
perfectionist.
a-
He's never satisfied. So Tarun, tell us, what are
We
you
may
saying?
have a little bit of a medial dive.
Yeah, so a little bit of medial dive here, and
Okay.
maybe we need just to.
I agree. I agree. I think we can just loosen up.
Yeah.
And maybe to
It's a
counter it a
I
little
think,
bit, just.
the valve may be pushing it, so if
Yeah.
we come away from the valve, then we can...
Okay. All right. Shall we? So let's go ahead and check our clasps. So this is the light one.
Anterior.
So that's
So that's
anterior.
the anterior. Did you guys see that?
Yep, we see it.
This is posterior.
Good. Perfect. Yep.
All right. Okay. So are we too medial?
Well, let's put the color here and see here. We might be just on, I think there's a little bit of medial dive, so maybe if we can take some flicks off to make sure we're not gonna be going to the commissures here.
And the other thing that's a little bit different here is when you move medial lateral, you don't have to move the entire platform. You can actually just slide it within the whatever that's called, whatever it lies
The
on.
precision system. Those.
Yeah,
All
it's-
right.
Because
Okay.
because Korea is not available with this device, I think also in most of Asian country it's not available.
Yeah.
In this device.
this is new learning here.
Yeah, new learning. Yeah, that's right.
Okay.
Okay, I think it looks very good and
Okay.
reasonable
So
here.
we'll close it and we'll go in. Do you agree,
I do,
Moody?
Yes, I agree, yep.
but Moody matters, not me.
We all have to be agreement, this is a very democratic procedure.
It is? With Raj? No.
They told you I was like, all right, no more, no political.
No politics. No, you can't have politics here.
Yeah. Okay. So we are going in.
It's pretty deep. It will go deeper when you open.
Okay, that's, you're under the leaflets nicely here. Yeah,
Okay.
for the
So I
color.
think, so the important point here is not to go too deep because when you open, you are going to descend anyways. All right.
I think that feature is different from clip. This seems to go down more
Yeah.
compared
Yeah.
with clip when you open.
Okay. So as you see that we are much lower than what we thought because as we open, it descends.
And
Now there
that's
is a
touch it.
cord. Is there a cord there, right? In the posterior?
Yeah, but so we're checking here, the position-wise, we're gonna check. Looks very good here in the middle. And the
Yeah.
anteroposterior is a nicely balanced between them. It's not.
But is this a little bit more in the middle than what we actually
we'll check
originally?
with the color because here on the 3D, it looks like you're just here on the side nicely. So we can check the color and see how far you are from it. Maybe, we're gonna need to push it a little bit in. I mean, pull it back a
Yeah,
little bit
pull
more
it
medial.
back.
Yeah, that's what I
Okay.
mean.
So, or maybe also tighten the flex a little
Yeah.
bit.
Because as you see here, there's a little bit of color coming from the side here in this view. So we want to bring it back a
maybe
little
pull
bit
the
to be
system
in this
back,
position, I would say.
Okay. Nicolette, I think we need to come back more, right?
Yeah. I would do
Okay,
the
so
whole
I
thing.
think we can. Okay, that's
great.
better. All right.
And
Way
having-
too much now.
Okay,
Okay.
so now we're gonna
think,
go and check the orientation one more time.
Now we may need to release some flex. We're too medial now.
Yeah.
I think you're right. We have
So-
come to medial.
It's
So
probably that flex transmitted as we move.
Yeah,
we can also just allow a little bit of clocking.
Moody, do you want to put color and see position?
yeah. So
It's not bad though. The color is not bad.
it's not bad, it's just like, we don't want to be getting caught in the commissure over there. So maybe you want to move it a little
Push the
bit,
system in.
Okay.
either
Alright.
pushing it or.
Okay, Tarun, push it in a tiny
Yeah.
bit.
Okay,
And
I
this
think
is a lot,
very good.
especially in degenerative MR, there's a lot of interaction between the cords and,
Moody, how about now? Looks okay now?
yeah, looks very good here.
Okay.
And I would counterclockwise it a little bit, as you see here, the orientation.
I think the other difference you can note here is see how much more flexible the clip delivery catheter is. It's really moving with the mitral valve much more than you would expect with a mitral clip. It's very different on the last catheter.
Yes. And here you can see here on the color here, we just have a small jet on the medial side. And I think it's very reasonable here to start and try this part.
I think the anterior leaflet is going in and out.
Yeah, so the anterior is in and out. So should we just take the posterior first?
If you go down a little and then come up, Raj.
Okay, let's see.
Okay, now come up.
There it is. Anterior's on now, I think.
Okay.
If you come up more, I think both will settle
I
nicely.
think I was thinking about optimizing one. Okay, where is the anterior? Light. Okay, so it's less than perfect.
We'll go
Not at all
posterior
perfect
now.
actually right now, but let's go posterior. Let's get the...
Posterior looks very good.
Okay, what do you think, Muri, about posterior?
I think we have a lot of posture. Yeah.
It would come up more. Yeah.
No, okay. Because we've lost the anterior, or maybe just have it by the tip.
Let me try to get you a good image here.
Maybe we should just let go and just go down
Yeah.
and try and get both.
Absolutely.
All
We're
right.
going to need to check the orientation because I think the orientation has changed here.
Looks pretty good.
Okay.
I think we're off. Yeah.
Okay, Muri, what do you think?
Yeah, we are like right now 11:30, and
Yeah.
so we need to clockwise it a little bit.
All right.
And we have to always, initially want to go medial first, but we find the medial side is more difficult. We can go lateral, and then after that get the medial. This device allows us more flexibility and less entanglement.
Right now it seems like we're in the cleft, between the scallop and the.
So we have to
Yeah.
push the whole thing in then.
It's analog.
Why don't you
Yeah.
just go in?
Yeah, I think this is a better position.
Yeah. So we may have, okay.
Put the color here. Position Y looks good, so let me give you a good 2D. You can see here the anterior leaflet is sitting nicely here, and the posterior leaflet is sitting nicely. Both of them, we have both of them.
Do you think the posterior is
But
curling
it's-
a little, or is it okay?
I think it's okay, just curling by the nature of it, but we can always optimize it once we get.
Posterior was.
Sure.
And this is the big advantage of having.
Okay, so
the-
let's optimize posterior. Let's go posterior.
You also want to come a little higher before raising the
We can.
Okay, perfect. Yeah.
Posterior is dark.
So you just raised the clasp posteriorly, I see, and now
That's
back
correct.
down. Yeah. Okay.
Yeah.
Yeah, if you could let us know that, that's just to guide us, that would be helpful.
Yeah.
Yeah.
Okay,
pretty
so,
And we saw it. We captured the video, the scening of the.
all right, shall we close?
Yeah.
Muri, do you want to put color as we close so we
Sure.
can see?
But see, the thing here is that we've got a jet on both sides. We haven't lateralized the jet. And what do you think, Moody?
I mean, it's definitely a good reduction. Maybe, we can end up with 3 devices here because the jet is so wide. We'll see here, based on the hemodynamics assessment we can get. The first thing we're going to get is the gradient, making sure that we didn't cause any stenosis, which is very unlikely. in the first one.
Yeah, I don't think gradient is a problem. I think to me the key question is, are we really happy with the quality of the grasp? I have to say that,
So the quality of the grasp here, we can have it here. This is with the optimization one. And
The other nice thing about Pascal is you can, do a very nice hemodynamic measurement of the LA pressure during deployment. A lot of people like that. You get, unlike the
Yeah.
MitraClip, you get a much more
okay.
high fidelity signal.
Moody, what suggestion do you have?
so-
Should we
so
further
here-
optimize?
Yeah, let's do a 3D quickly and look at it and make a decision if we're going to move it to the side or. because we have two Shih-Hsiens right now. So
Yeah, so I think what we have is, our original strategy was that we will,
we still have the two Shih-Hsiens coming from these sides here. So I would move this one a little bit more lateral
yeah.
to have it, and then it would be easier for us to get more tissue on the medial side.
Okay, so we're going to raise,
So let's go back to grasping view, Modi.
Yeah.
So you're going to go back, you're going to go more lateral first
yes,
and go
yes.
medial with your second.
We are
arm.
changing our strategy on the fly. Okay, so because we would like to lateralize this and see if we can get away with 2 devices rather than 3.
Yeah.
Okay, so we will raise our, okay, and then,
I'm gonna put the color here to move it as lateral as possible
To
here.
come up a little, it's really deep before we move.
I think,
Okay. That's better.
yeah, all right, so I think we should move this. Okay, so we're going to move the whole thing.
Okay, how's that, Modi?
That looks very good here. As you see here, we moved very lateral, and there's just a small whiff here on the side.
Okay, let's check orientation.
Okay. So orientation looks good,
Yeah.
as you see here.
Nice.
And we are on the lateral part, as you see. And when we put the color also here, you can see that it's much more lateral than we were initially.
Yeah. Okay, let's go to grasping.
In grasping view here.
I think this really shows, this is the difference between MitraClip or Pascal and TAVR. TAVR is all about the planning, and mitral TEER is all about improvisation. You have to be able to think and adjust as you go.
Raji, usually in the Pascal is opened 180 degree to the.
The capture ready, they call it. And that's right at 180
You
degrees.
come up, Raj, I'll steer for you.
It's somewhat different.
It's
Magically.
everything is different.
Yeah.
If you Come
Mm-hmm.
Kind of the
up,
same.
I'll
but
steer,
different. Does anybody else on the panel have experience with Pascal, or is it not yet available? I think I'm the only one.
probably high enough.
I think I'm the only one.
So we have the posterior leaflet and we have the anterior leaflet here, as we see.
Nice. Posterior looks great.
Anterior is white. Anterior is white.
Dark is posterior.
Do we have posterior properly, the way we want it?
I think we are so close to the cleft, it's we may not have the whole width of the leaflet
Yeah.
because it's slipping in and out.
Okay, so what do you see?
I think it came out right now.
But we may need to come just a tad medial so we come away from the
Okay, so let's go down a little bit.
yeah,
Let me also, I think,
just like a tad medial.
And now
That
you
should
can
be
see
good
it's,
enough. Yeah.
And you're doing your medial lateral adjustment just by sliding the entire
that's correct.
system, right? Yeah.
you can see the leaflet is all the way there inside, and the leaflet is,
Now let's optimize the posterior.
yeah.
We'll go posterior, posterior, posterior. All right.
Yeah.
I don't think we should raise it anymore right now because otherwise
Yeah. Slip out.
we'll slip out.
Yeah.
You can see here we have a lot of tissue.
Okay.
Are you happy with the anterior as well?
Are we happy with the anterior and you want to look at the orientation?
Okay, I'm gonna go and check the orientation. And one,
So Raj, when you are optimizing, are you're raising the clasp and then relowering it, correct?
That's correct.
Yeah,
So we raise the clasp, we go posterior, and then we
looks very reasonable here.
we relower. A lot of times we also bring it up, but here we were so high anyways that we were concerned.
And
Now,
again,
it's a little bit rotated, but I think we can try close it and see.
Yeah.
Yeah.
Even on floor, it's the way it's moving. But I think this may be pretty good for the first grasp.
Okay. All right, shall we close it?
let's close and see. Yeah.
Yeah.
Okay, I'm going to give back a little bit, just a little bit. Okay.
Oh,
So
You
far,
still
looks
have
pretty
this.
good.
yeah, good.
So there is reduction, right? But we
Yeah.
may have no choice, but what is the gradient?
The gradient right now. And this is a heart rate of 69. It should be still acceptable. Two.
Two.
Two is good.
Okay, all right. Okay, so the question is, do we have a jet lateral? We do have a small jet lateral.
Yes, we have a small jet lateral and we have a
I think the big one is medial.
medial. But it could be too big to have two devices. I mean,
Yeah, I mean, the
you might
valve
need
area
to-
is 10. So, okay. All right. So if you agree, then, I mean, at some point we'll have to take a decision. We should release this and then get to the business of putting the next one.
So Raj, we're about halfway through, and I don't know what your other case is and how you want to organize.
Okay, so this is what we can do. We can actually, Mamu, can you hear me in the other room?
Yes, I can hear you. Can you?
Yes. So I think we have a very interesting case in the other room. Why don't, Mamu, go ahead and actually show your case, and as we had planned.
Okay.
Yeah.
Yeah.
But
And-
go ahead and show your case, and then
we come
hopefully
back and
we'll
see-
come back here, and then we'll be back there or something.
Yeah, I think
like
we can,
that.
Raj,
Okay?
we can come back to you after is it a TAVR case, the other
Yes.
one?
Yes.
Yeah, and then if you're still not done, then we will come back at the end of the lectures in a half hour
Okay.
later, okay?
Okay. All right. Terrific. Okay.
Hello, how are you? I see
Hello,
Akriti. Hey,
good
Akriti.
morning.
How are you?
Hi.
Hi. Well, thank you for inviting all of us. While Raj is doing the mitral case, let us get started for the TAVR case, and hopefully we can make a interesting discussion, some provocative discussion for the future treatment for the TAVR also. Let me introduce our team in here. Raj supposed to be here, however, he's in there. So my left side, this Dr. Gupta, our youngest new faculty in here. And my right side, Dr. Bansal is a new structural interventional fellow. Dr. Wen Chen always supporting for us for the TAVR program. We have the whole staff anesthesiologist, Dr. Stewart is anesthesia, and Dr. Saba Scarf and helping us for the TE. We have the catheter staff and Paul Kim from Korea, and Hannah and Nancy in the control room, and John from Korea as well. We have the supporting staff from Edward and Tejas and helping us to prep the bar. So, Priya, why don't you just start getting the presentation from our side of the case? Please go ahead.
This is a 77-year-old female who presents with worsening shortness of breath and fatigue, along with New York Heart Association Class 3 symptoms of heart failure and a rising BNP. She has a history of a TAVR in 2017 for severe symptomatic bicuspid aortic stenosis using a 23mm Edwards Sapien 3 valve at that time. Her past medical history is significant for a dual chamber pacemaker, a TIA, atrial fibrillation on apixaban, hypertension, and hyperlipidemia. Next slide. Her most recent transthoracic echo showed a normal left ventricular function and mild to moderate central AI with a mean gradient of 39 millimeters of mercury. Next slide. Her transesophageal echo done this morning showed restricted motion of 1 out of the 3 leaflets and no significant AI, but as you can see, there is turbulent flow across the valve. Next slide. So to review, let's review from 2017. Her baseline CT prior to her initial index procedure showed an annulus of 403 millimeters squared, an LVOT area of 381 millimeters squared with no significant calcium of the annulus or the LVOT. She had a type 0 congenital bicuspid aortic valve with mild to moderate stenosis, calcification of the leaflets, and no associated aortopathy. Next slide. Her TAVR was performed with a 23 millimeter Sapien 3 that was deployed at nominal volume. There was no significant AI noted on fluoroscopy, nor was there a waste of the valve frame. On day 1, her transthoracic echo showed a mean aortic valve gradient of 19 millimeters of mercury. Next slide. She had a routine 30-day post-TAVR CT as part of the RESOLVE registry. At this point, she was not on anticoagulation for her atrial fibrillation because of GI bleeding. The CT showed significant hypoattenuated leaflet thickening with significant restricted leaflet motion greater than 50%, particularly of the left coronary leaflet. Next slide. She was treated with rivaroxaban 10 milligrams daily for 1 year, and then a repeat CT was done. At that time, you can see that there was reduction in the halt noted on the left coronary leaflet, but notably there was increased thickening along the base of the leaflets, suggestive of either thrombus or pannus. Next slide. There was a progressive increase in aortic valve gradients over the last 6 years. As we mentioned, it was initially 19 millimeters of mercury on day 1 post-TAVR, and it's increased slowly to 39 millimeters of mercury 6 years post-TAVR. Next slide. So in anticipation of the procedure today, we repeated a CT, and her annular area was 331.6.
Oops.
Sorry, we lost the slides.
There we go.
Her annulus area is 331.6 millimeters squared, and her coronary heights were acceptable from the beginning, but you can see that the stent frame, it lies below both of the coronary ostium, and the valve to coronary ostium distance on the left is 6.2 and on the right is 5.6, both of which are acceptable. Next slide. This is basically cutting the valve across, and in the mid segment, you can see that the area is 400.2 millimeters squared, and there's a significant difference of the inflow and outflow areas of 431.7 millimeters squared and 442 millimeters squared, respectively, suggesting a waist in the middle of the valve. And the cross-section of that, you can see on 4D, shows an area derived of 1.2 centimeters squared. Next slide. If you compare the CT in 2017 to our most recent CT, there's no recoil that is visualized in the valve frame. Next slide. Brachiocephalic and left carotid anatomy seem suitable for sentinel cerebral protection device. Next slide. So our case plan for today is to pre-dilate with a 22 millimeter true balloon, use cerebral embolic protection using a sentinel device, and do a transfemoral TAV and TAV with an Edwards 23 millimeter Sapien 3 Ultra Resilia valve. Thank you.
Well, thanks.
So,
that was great. All that imaging is impressive and really helpful.
Yes, so we have this patient we did a 23 millimeter Sapien 3 and several years ago. It's a bicuspid aortic valve, and the TAVR, Raj did it, and unfortunately, valve have the thrombus and leaflet on there, and then we did anticoagulation for a while, but the gradient was still remained high, and recently gradient even getting higher, despite of all those whole medical management, also start developing the mild to moderate aortic insufficiency. She's clinically stable from symptomatic standpoint. However, for chemical factors such as B and P started elevating it. So she's a relatively young person. So we decided to just go ahead and doing the new valve. And I think we have the discussion like whether we should go for the next one with continuously doing the less invasive approach or go for the surgery. And I think Kriti knows about the patient a little bit more, and you may have a little bit of insights for that.
Sure, yeah. So I think the discussion around this was, firstly, do we even need to do a procedure? And we should take a tour of the valve with the TEE, and I'll have Sabah introduce the valve soon. But the discussion was that the leaflets are opening, so do we need to do a procedure? But given that she's symptomatic, she has an effective orifice area of 1.2 with pannus ingrowth pannus or thrombus circumferentially, suggesting valve regeneration. She's symptomatic, has a BNP that's very elevated. So all of that led us to decide that she needs to be treated. And then choice of valve. So should we go with a self-expanding or a balloon expanding valve if we had to do redo TAVR? In the self-expanding, the discussion was that we could do it. Question is, they do tend to degenerate fast, and if a self-expanding were to degenerate in the next five years, let's say, because she seems to be someone who has predictors of degeneration, then we will be very limited in our options for coronary access. So given all of that, we decided to go with 23S3 with Resilia, hoping that what is promised with Resilia is going to bear out in terms of decreased gradients and better durability, given that Resilia tissue seems to have proprietary anti-calcification technology. So we'll see if that works out.
Can we?
Any question or comment from the audience side?
Yes, so remind me how old this patient is now?
She's 77.
77. So I'm curious to hear from your cardiac surgeon if he's mic'd up to about, was a surgical option reconsidered, or Akriti, maybe you can tell us just in terms of, if it fails again in 5 or 6 years, she's, then she's third valve in, we're getting the real estate's getting tight there. So what did you think?
Yeah, our surgeon is unfortunately not mic'd up, but,
Okay.
Dr. Cheung, there we have a mic for you. So in terms of surgical feasibility for her, what were our thoughts?
Well, we could take this valve out and put another valve in, but I think TAVR is a reasonable option. We have plenty of room in the sinuses, and
the other thing is most of the data also shows, right, that explant surgical redo TAVR, TAV and TAV is sort of better in terms of outcomes than surgical explant. What do you guys think?
Is there anybody on the panel who would do something different than this? We have a number of experienced TAVR operators here. Anybody want to choose a different valve or a different approach?
Yes, thank you. So I think it's a very recent approach to do TAVI here, but I definitely would put now a different valve, but it's same platform with Resilia is one option. While I do not have that option, I may choose another platform like the self-expandable platform. I think both are very reasonable.
Yeah, I think your thought process, Akriti, makes good sense, regarding thinking ahead, because the most likely thing is this patient's going to need a third procedure. It seems, unless, her risk, she has other conditions that are life-threatening. So I think that's the key, is to make sure you really are not closing doors.
So I have one question. So for the pre-dilatation, it seems it's planned for a 22 true balloon. And I'm just thinking about why not just direct adding some volume on it. I will go back to the original CT, so how much expansion I can achieve further, because a gradient will not be a big issue, but it's still something I would like to optimize. So in case I can optimize original frame a little bit more, so that I can place Sapien, for example, with some more expansion to a certain extent, maybe a good thing. But why a 22 balloon for the pre-dilatation?
Can we see your fluoro image while you're working, Akriti? There we go.
Yeah.
So that's a good question. I think we should probably mention about it in the CT. If you look at the CT, actually it was reported this first about what's deployed in nominal, the volume, when the Raj is the first valve. But if you look at the CT, it's actually in the mid segment via this valve. It's not completely rounded. It's a bicuspid valve. It's very expanded for the commissural side. For the valve side, it's actually slightly under-expanded. I think they decide not to do too much aggressive dilatation because it poses a risk for the rupture, etc. And they decide to accept it. Actually, Saber, you're doing the TEE. Do you have anything for your comment, anything specific you would like to mention about this particular first valve?
As you see here on the screen, Mamu, this first valve, out of the 3 leaflets, the one in the left coronary position is completely immobilized. You could see how the edges are thickened and look raised. So could be an indicative of pannus. So it's probably long-standing degeneration. When we look at this valve in transgastric views, you do appreciate that AI, so there's also this sign of degeneration. Now, when I measured the frame from transgastric views, because it's easier to really see, the distal end of the frame measured about 22, so there's probably some under expansion, despite that it was given nominal volume. And if you look at the waist area of the valve, it's even smaller, 21.5. So there's a bit of differences, as you could see on these images.
So it seems like there's a combination. The valve is probably expanded at the beginning for the safety reason, whatever the clinical reason, and also leaflet is also degenerated. So now I feel this valve needs to be fixed, but in order to optimize the second valve performance, I think somebody from the audience bring up the good issue, like whether we should pre-deal to just stretching out a little bit how much it's going to impact, and nobody knows about it. Do you have any comment from the panelists or audience side? But we initially planned to do the pre-deal just because we felt like that may give us a little bit more, like an optimal second valve expansion, and then may be able to avoid this further aggressive post-deal.
Right, I think
the leaflet.
Our thought was also that it'll be much harder to overcome the radial forces of 2 valves eventually, because what we measured was that we wanted to reach 24 with our valve. And so we thought we can modify the first valve, not fracture it obviously, and then so that we're able to actually get good expansion with the second valve.
So your thought about the 22 millimeter pre-dilatation is to stretch the frame of the initial valve to give yourself as optimal a deployment of the second valve as possible.
Correct.
Yeah, I think it's
a little bit expansion. Yeah.
Makes sense. And I think a paper was just published by Janar Sethananthan showing that pre-dilatation was better than post-dilatation with 2 sapiens. So I think that's the strategy you're following.
I didn't know, I didn't know. So we're going to go ahead and do the 22 true balloon, and hopefully we can make it work. The pacemaker ready?
Are you doing any pacing on the wire these days, or still like many of us?
I think we are still doing the pacemaker wire and the RV. Because this is balloon expandable. It's just my anecdote, like we don't know. Like I just want to make sure, like a valve is not going to pop out.
I can totally understand. Yep.
We have capture.
A little bit opening.
That seems to have, you saw the waist seems to have.
Yeah, you see a waist, That's
Okay, well, hopefully this one that makes things easier and give us a little bit better performance for second valve. So hopefully we didn't make any additional trauma.
Can we check with TEE if everything is okay?
So right now we're seeing a lot more AI through the central portion of the valve.
So we'll put the
so we have to move fast with our valve. Yeah. Are we ready for the valve?
What we'd like to do, like we don't want to put in the high, just gonna try to place it a little bit lower, so that we can avoid the future interaction between second valve and then if we need a third valve with the coronary austere. Okay, let's go for the third valve, please.
So while we're preparing the valve, so just some interesting points about this case was also that, we looked at our Cedars data and we tried to replicate the findings of the Fukui paper for deformation. And we found very similar things, including that if you have prosthesis deformation, it is a predictor of halt and potentially worse outcomes. But an interesting thing we also found was if you have a bicuspid valve at baseline, that also predicts deformation. And in our case, this patient had a baseline bicuspid valve, eventually developed halt, and we're seeing early degeneration. And that's one of our hypotheses, that patients who develop HALT may not have significant clinical outcomes that we know about so far, but may actually end up predicting degeneration.
Well, that's an
And
important
this case
hypothesis.
sort of exemplifies that.
Yeah, we really need to know the answer to that to know whether strategies to prevent HALT are worth doing, because they all involve anticoagulants and bleeding risks. So we need to understand that for sure.
So do you apply cerebral protection device Sentinel now?
Yes,
already, I think.
Already.
Oh, yeah,
in
let's
fact, we
actually show
already
them. Sorry, we skipped
we
all of
already
that.
did it while Dr. Banstein presenting the case. We just anticipated it's a little bit unpredictability, like just do the pre-deal may cause the emboli from the old degenerating valve material. So we did a Sentinel over here.
Yeah.
We are still preparing the
That
valve.
was our
I think it's going to be
cerebral
ready
vessels,
anytime
and we
soon.
did end up inserting. I can show you the fluoro. It's a little bit of a tough insertion, but we have Sentinel.
Looks good.
We tend to do that in cases where we're predicting post-dilation or valve-in-valve cases where we think are potentially high risk.
Is your patient stable? The blood pressure is okay with the AI?
Yes,
Yeah.
blood pressure is so far so good despite of the worsening in the AI.
Good.
Now
Yeah.
Leaflet
But it's
actually
it's quite a bit of AI.
Yeah, our
because
blood
as you
pressure
could
is 106 by 60.
okay.
Yeah,
So
and you can see
we're
the
gonna go
Leaflet.
ahead
Going
and
with the
put the
valve
new
now.
valve in.
And so you said you're going to try to place this a little bit lower, not directly superimposed on the original?
Or at least like a same level.
Yeah, same level.
I don't know how much we're gonna be able to precisely position this, but we'll try. Yeah, go ahead.
I mean, right in the same place would seem fine. It would look like it was perfectly positioned the first time.
This. Okay, so let me assemble this. Okay, just advance. We keep the nose over there a little bit there.
But I do think this points out the the importance of probably in the optimal world having your valve all ready to go when you pre-dill, so that you don't have to worry about.
Yes. So it's just
it's
sort of
okay.
an
a little bit
oversight.
disorganizing today.
We've never had that normal.
Okay,
Yeah,
hold on.
just for
It's
safety,
a-
it's
okay,
nice.
Keep it going here. All right. Well, hopefully we can make it coaxial.
Which wire are you working on? Is that a Safari
keep
or is
going.
that what are you on?
This is a
Amplex extra.
Amplex extra wire.
Oh, okay.
Okay, we're gonna be able to go.
Cell-shaped. Great.
Advance a little bit. Hold on. Give me a second. Don't do anything, please, like in front of
Can you
me.
pull the probe back?
Okay,
Yes.
just go advance a little bit more. A little bit more. Okay, stop there. And I think we're gonna just take the pusher out. Shake back in here. And put the
It's
chain.
hard to be flat.
Now come over here. We just hold this together. Okay? We don't need a contrast. I think we have to go a little bit lower.
Yeah.
Yep.
Yeah, that's
Over
what I'm
here?
gonna try to do because it's gonna go going up a little bit. How about in here? What do you think?
I think it looks
Okay,
great.
so-
Your right top is superimposed, and you can watch the bottom and
Yeah,
adjust.
great. So we'll deploy this valve. Is pacemaker ready? On my call, okay? Cine, please. Pacemaker on. Okay, go ahead. Go ahead. Keep going.
Perfect.
Off, please. It's very tight.
Yeah.
Off, please. Okay, so let's just come out in here and ask the server to assess it. Activity, can you just deflect? That's great. And then put it back here, this one. Let's put it back then.
All right, so mammalian
Okay.
accuracy. Your
We still
second,
have the wire server.
yeah, no problem. But your second valve looks pretty much superimposed on the first one. That's what it looks like on echo. There's no more of that central AI we had earlier after we
Right.
ballooned it. And I don't see any paravalvular AI either. Now, in terms of your leaflets, now you could see all three leaflets moving.
Okay.
Looks
I
great.
think we're going to assess the hemodynamic gradient.
Right.
And if the gradient is still high and acceptable, we may do the posterior with the 22 true volume since we already have it.
So I'll get you a transgastric gradient non-invasively while you get your hemodynamic gradient.
Do you want
No,
to?
Okay, let's take this out.
I think you managed to line up the frame exactly. Didn't you? Get the line. You got literally
Yeah,
perfect.
we're so glad like we are able to put this valve like we discussed it before, right? I'm relieved.
The Doppler, the shape and like size of the Doppler obviously looks a lot better than earlier when we had like, I could show you what it looked at baseline. Right now, the mean gradient I'm getting is 3.
Okay.
This was my baseline gradient earlier.
Would anyone on the panel recommend post-still?
Anybody want to post-dilate this more aggressively? So you pushed that pretty hard with the, and that was a
The
nominal
first
fill?
one.
Was that a nominal fill or an overfill?
Was that nominal, Dr. Cheung? Plus 2. Plus 2. Nominal plus 2.
Nominal plus 2. I think you've done pretty well.
I still have the ways.
Yeah. I mean,
My preference is like to do the post-deal. And I have the reason, because I have the same situation recently. My own patient, I did the TAVR in TAVR. And the gradient, exactly the same way, like a little bit weighted space in between. Let's get the gradient first. And then like a gradient was the team right after finishing up in 1 month, like it went up to the 40. And I end up coming back and do the Bioprosthetic again.
Well, it depends on how much you think there will be a recoil on this valve.
Right.
Yeah.
So,
it seems to me as long as the leaflets don't thrombose again, you're going to be in good shape. So I think.
Exactly.
So Mahmood, did you post-dilate?
Not yet. We just deployed the valve.
Yeah.
I hear Raj.
So this is a gradient.
So the gradient went from, what's your hemodynamic?
We don't see the hemos.
Can you show them our hemodynamics,
Yep,
please?
we got it now.
Sorry for the lot of PVC from the catheter, but it didn't look so bad.
Yeah,
It's like
the gradients look
gradient
very good
negligible.
actually. 11.
Yeah, so I think this is pretty much like what we saw 5 years ago, right?
Yeah. Looks, I mean, I think it looks pretty good.
So I think if this can get another 5 years, or maybe this is Resilia, maybe it'll get longer, and then
That's
after
right.
that,
then you'll be
we can
retired.
consider putting a supraannular valve.
So that is, it's good. Like I don't mind to just leave this valve as it is.
Actually, our gradient is 6 with much better tracing.
My gradient is 5 on echo.
And echo gradient is 5.
I think that's all. Anybody want to do anything else, or are we done? Everybody's giving me the high sign that we think you're done. We think you did a good job for it. So again, I want to, Roger, we're going to go back to you now to finish up. Is that the plan?
We are still working. So are you? Do you have talks to do? Because
we have 2 talks for 20 minutes or so, and then we can come back to you and see where you are further. Does that sound fair?
Yeah, I think that's reasonable.
Okay, and let's just give a round of applause to Akriti and team for finishing up.
Okay, in fact, do you want to show this?
And so we will
Actually, you know what, David?
You want to go? Keep going?
David, if you come to us, we just put a second device, and we want to show you the result.
Okay, so you have 2 devices in now?
Yes, we have 2 devices. We haven't released the second device. Moody, can you go ahead and, okay, so are you showing, can you tell everyone what we have done here?
So we had a difficulty grasping this one, and mostly it's because of the cleft. Next to it there, we can show it to you. It was mostly the cleft that was here that made it very hard, that we had to change the orientation to be a little bit clockwise, 1230 to 630. And it was because of all the degenerative MR we had. It was curling around itself. But we had a very, very good, like you can see here, the leaflet is curling in this view here. So finally what we did is that we were able to change the orientation, elongate it here. That was a nice feature. You can see here we have all the leaflets anterior here and posterior. And we're trying to optimize as much posterior to take it, and then closed it here. And we had a very secure clip that we think is going to be secure enough, and reduction of the MR to this degree here right now.
Okay.
So are you happy with this, Raj? It looks pretty good.
Yeah, I mean, it looks good. The question is, are we going to put another device lateral? But I think, let's see. I think this is down to mild.
Yeah.
And the gradient and the gradient is also pretty acceptable. I think it's less than 5. And, based on some of the analysis that were done from TVT registry, if you have mild MR and if you have gradient less than 5, then you really do well, in terms of your long-term survival and rehospitalization and re-interventions.
I mean, that's
so. And you
that's
can
the
look
goal.
at the Moody, you want to comment on this?
The primary veins, as you can see here, it's diastolic dominant, but it was blunted before, so it's definitely improvement there. And we're going to go and check the right one too. So definitely there's a good reduction here, and the gradient is still acceptable in this result. As you can see, now it's co-dominant, even systolic dominant at some phases here. So it's definitely, down to mild MR at this point. And we'll show it to you the 3D how it looks like.
I think as long as it stays like this when you release it, I think I would be pleased.
Yeah. And you want to show it in 3D? Yeah, show the color in 3D, Moody. Yeah. So I have to say there, it looks pretty good actually.
Yeah.
Maybe a tiny whiff in between the two, very tiny.
Jets over there and so on. And we know that we have still this, lateral jet that we're going to put a third device in since the gradient is still 3. So.
Okay.
So what was the LA pressure before the procedure? I think I can see the LA pressure in this monitor.
Yeah.
After procedure.
The LA pressure, I have to say, was never very high actually.
I mean, we see this from time to time. Again, it was not, it wasn't the worst case of MR. It was not, you didn't have pulmonary vein flow reversal or anything like that. So, I mean, look, but that's a normal left atrial pressure. That's what you have now, for sure.
Okay.
So, do you want to let it go while we watch?
Yeah. So we are going to let go, and then we are going to decide whether or not we will actually put a third device. But I guess.
So why don't we let you guys let it go, then we'll give the 2 talks, and then we will come back to see where you decided to finish up.
Okay, terrific. All right, let's just go ahead and release this.
Let him just watch the releases. I guess we went off. All right,
Yeah,
so we'll come back to you, Raj.
Yeah, it's perfect time to move to the lecture. First lecture is the moderator David Cohen, Cardiovascular Research Foundation, USA. He will talk regarding challenging with the valve TAVR, role of bioprosthetic valve fracture, coronary protection, and lift modification. David, please.
Thank you very much. It's a great pleasure to be back here once again this year and to watch some really interesting cases. And I've got a lot to cover in a very short period of time, so I'll try not to slow down. So valve and valve TAVR, we've been talking about it for 2 days now. It's still about 5% of all TAVRs in the United States, and there are 2 really main challenges that we have still with valve and valve TAVR. One is patient prosthesis mismatch, especially when we're treating small surgical valves, and the second is the risk of coronary obstruction. And this shows really the risk of patient prosthesis mismatch. This is original data from the VIVID registry of valve and valve TAVR procedures, and you can see the 1-year mortality in patients with small versus intermediate versus large-sized surgical valves is very different, and this is held up in other studies since then. And so this really confirms the role of patient prosthesis mismatch and the importance of avoiding this for our patients. And so there are really 3 things today that we can think about in trying to limit this when we're doing valve and valve TAVR. The first is which device we select. Between balloon expandable or self-expanding valves. There actually was a small randomized trial published last year called the Lightens trial out of Canada, which randomized about 100 patients with small surgical bioprostheses to balloon expandable versus self-expanding valves with a primary endpoint of gradient. And perhaps not that surprisingly, the gradients measured by echocardiography at 30 days were substantially lower with the self-expanding valve, and as a result, there was a difference in severe patient prosthesis mismatch as well. We don't know the clinical consequences of this. That has yet to be seen, and as you know, there still are controversies regarding whether the echocardiographically versus transcatheter-derived gradient is more important. But again, I think this certainly suggests that in managing a small failed surgical bioprosthesis, there may be an advantage to using a self-expanding platform. The second thing that we can do, regardless of which platform, is to put the TAVR valve in the right place. This is a simulation study done from Dr. Simonato and group, published a few years ago in Neurointervention, in which you can see here whether you're using a self-expanding platform or a balloon expandable platform. What you can see, if you look at the mean gradient, the lower you place the valve, the higher you place the valve, again, more into the aorta, the lower the gradient. And this is true whether you're using a balloon expandable or whether you're using a self-expanding platform. And so again, the general rule of thumb here, again, if all else is equal and there's not an issue with coronary obstruction, is try to place the TAVR valve about as high as you can in order to maximize the valve dimensions. And then the third principle that we've been doing now for about 7 or 8 years is the idea of bioprosthetic valve fracture. We discussed this a little bit yesterday. And just to remind you what this looks like, I think it was about 6 or 7 years ago that D.W. Park and I did the very first case in Korea here for this exact meeting. This is a patient with a 19 millimeter Magna valve, which has a true ID of 17 millimeters, and we did initially a transcatheter, a valve-in-valve with a 23 millimeter evolute. This is the baseline gradient, 63 millimeters of mercury. Here is the evolute being performed, and then here is the gradient after placing, it's not a 26, but a 23 millimeter evolute. And you can see here that the gradient really hasn't gone down very much at all. We actually did a low pressure post-dilatation. It didn't change very much. And so this is a case that we decided to treat after valve implantation with balloon bioprosthetic valve fracture. You can see dilating this with a non-compliant balloon, in this case a true balloon. And you can see right here where the pointer is, the valve release when the band fractures, and the gradient after valve fracture was reduced to 18 millimeters of mercury with an acceptable valve area. And so this really is what we like to do when we're treating these small surgical valves. A secondary advantage of valve fracture in these small surgical valves is the possibility that we may improve valve durability by really expanding the valve better and then allowing the valve leaflets to function more. So this is a case where you can see the valve-in-valve has been done in a in vitro model, and you can see this pinwheeling, and then after the valve has been fractured, you can see that the transcatheter valve is much better expanded, and there is no pinwheeling. So this is a secondary advantage. We don't know if this will yield long-term benefits, but we think it shouldn't be harmful at the very minimum. If you're thinking about doing valve fracture, you need to know which valves can and can't be fractured. So this is a list of the common valves used in the United States that can be fractured. Very importantly, the Magna and Magna E's, which are among the most common aortic valves that are used, are fracturable. The MitraFlow also, the Perimount, and now the Inspirus valve, which is a valve made specifically for not even valve fracture, but with an expanding ring. So all of these valves can be fractured or expanded. Then there's a secondary set of valves that includes the trifecta valve that we were discussing yesterday, where the valves can't be fractured, but they can be remodeled, what we call bioplastic valve remodeling, where you expand the posts of the valve. And then finally, there are the valves that can be neither, the Avallis valve and the Hancock II valve. You can't budge these at all and shouldn't bother even trying. In terms of valve remodeling, in case you haven't seen a case of this, is a patient with a 21 millimeter trifecta with a true ID of 19. We did a valve-in-valve TAVR with a 23 millimeter evolute, and then even after the valve-in-valve TAVR, the gradient was still 29 with a great valve area of 1.0. And so this is the original, this is the valve remodeling, and what you can see as we inflate the true balloon, you can see the expansion of the frame here, and then as we let it down, the frame will stay expanded. And so we have bent the posts. We haven't fractured the ring at all. And now in this case, we're able to get a substantial further reduction in the gradient. So again, if we have a trifecta valve or one of the other remodelable valves and we have an unacceptable gradient, we will frequently do this procedure as well. Let me shift gears then for the last few minutes and talk about coronary obstruction. This is a really feared complication of valve-in-valve TAVR, but really of all TAVRs. There was a recent publication from Spain showing about a 0.8% incidence in all valves, but it's about 5% in valve-in-valve TAVR, so it's about a 6-fold increased risk. And the in-hospital mortality, if you get a coronary obstruction, is 37%. This has been really constant over time. Most of the cases occurring during the procedure, but there is a measurable risk of late coronary obstruction. And the main risk factors for coronary obstruction include small sinuses, low coronary height, so again, we're going to be interacting with the leaflet, and very importantly, a very small valve to coronary distance when we measure this by the CT of less than 4 millimeters. And then finally, one of the really bugaboos of our field is surgical valves with the leaflets mounted on the outside, in particular the MitraFlow and the trifecta. Here is a 21 millimeter MitraFlow, and you can see here the valve to coronary distance that we're measuring to the left coronary is 2.8, and the right coronary is about 1. And so this is a case, if we're doing valve and valve TAVR, we really have to think about protecting those coronaries in some fashion. So how do we do this? There really are two main techniques for preventing coronary obstruction. First, obviously, is recognition of the risk and the CT analysis. Then one of the options, and the one that is easier for most of us to do, of course, is protection with a wire and very often a stent already implanted in the coronary artery, just waiting in case the valve obstructs. So we have a safety wire and we have a stent in place. We place the transcatheter valve, and if there does seem to be obstruction, then we can go ahead and pull back the stent into position and do what we call a chimney or a snorkel stent, where we are stenting alongside of the valve frame. And if we have to post-dilate, we have to do a kissing balloon. And the idea here, again, is to just preserve that opening so we can get flow past the edge of the transcatheter valve and into the coronary artery. Obviously, one of the real challenges here is you're pretty much not getting back into that coronary if you ever have to come back to do any work distally. So this is kind of a one-time procedure and is a good mechanism if you need it, but may not be optimal for all patients. The alternative, which is getting more traction, but still I think is underperformed around the world, is the idea of leaflet modification. I'm going to show you a case that we did recently at St. Francis Hospital. This is a trifecta valve, again, a valve with the leaflets mounted on the outside, who had very, very low coronary heights of 5 and 7. You can see the valve to coronary distance, 2.4 to the left, 2.0 to the right coronary, and so we've got risk of obstructing both of these leaflets. And so what we plan to do is a small TAVR valve with a 20 millimeter S3 to preserve future coronary access, but double basilica. And so I'll just walk you through the procedure here. So we're doing the right coronary first, the right guide, and we have a snare positioned below the valve. You can see what we're doing then is just positioning, and then you'll see the crossing of the wire. So we electrify this wire, it's an Estado wire, and we burn right through the base of the coronary leaflet. And then once we're in the LV outflow tract, we snare that. And then what you can see is we've actually exteriorized this wire, and then we've made what we call the flying V, which is an area where we denude the wire in the middle, and we shape it with a V, and that's going to be what delivers the electrical energy. Now you can see here on the right, the secondary, now we're getting ready to do the left coronary cusp, so we have a modified Amplatz catheter called the pachyderm catheter that we're using. We're just checking the orientation in 2 positions. And then here is the wire traversal through the left coronary cusp. Again, electrified wire through the left coronary cusp. And now we have 2 flying Vs in position, so we have both ready to go. What you can see here is electrifying the wire and pulling and doing the valve laceration on the right cusp. And then here is the same thing on the left cusp. Once you do this, the patient does usually have a fair amount of aortic regurgitation. The first one is generally well tolerated. The second one, you have to move a little bit quickly. Here we are now placing the transcatheter valve, the 20 millimeter S3, in the normal position. And if we had not done the double basilica, I'm sure it would have obstructed both leaflets, but you can see in this case, very nice flow down both coronary arteries. So that's the idea. Now, this is a challenging procedure, and we're lucky that at St. Francis we have Jaffer Khan, who's one of the world experts in this procedure and is teaching us a lot about it. There are innovations coming to try to make this simpler. So one is a specific purpose-built basilica system called the Telltale system, which has a wire that is insulated, which makes it a lot easier, and then it comes with ancillary equipment to allow you to bend, make this flying V, to denude it. So that simplifies things greatly. And then what a lot of people think is going to really revolutionize this field is the idea of mechanical leaflet splitting with a device called the shortcut. This very brief animation here shows the idea is that you advance this device and you can steer it into the cusp, and then you open this inner part, which exposes a blade, which then is sort of captured by this external rail. and then the device is gradually pulled back and you get mechanical splitting, not electrical cutting, in this case, mechanical splitting of the leaflet in this very nice animation, which makes everything look perfect, of course. And then you have, again, a very nice splay in it that can be treated with a conventional valve-in-valve TAVR. So just to summarize, valve-in-valve TAVR is going to be important for many years to come, but there are several unique challenges. Patient prosthesis mismatch. We can minimize this by selecting the device and placing the TAVR valve, but if necessary, bioprosthetic valve fracture or remodeling is a technique that can reliably improve the short-term hemodynamics, but we don't yet have any long-term evidence that this is truly beneficial. We just believe it is. Coronary obstruction. Planning is the key, really recognizing this possibility based on the CT, measuring all of the valve to coronary distances and the leaflet heights. And then in addition to coronary protection and chimney stenting, I think Basilica and then some of its newer iterations are promising for prevention of coronary obstruction. But I think really what we need is these newer devices, these purpose-built devices, to make this easier for all of us to do, to be able to be teachable and reproducible for the future. Thanks very much.
Thank you for your great lecture and very comprehensive review for the valve-in-valve TAVR procedure. So let's move on to the next lecture. Is James Flaherty, Northwestern Plum Cardiovascular Institute. He will talk regarding transcatheter therapy for the tricuspid regurgitation. Has the future arrived?
Thank you, Chairman
James,
Kim
yeah.
and Chairman Cohen and distinguished panel. I'm involved in a few of the tricuspid studies. So over the last 10 years, we recognize that TR is a dismal disease up there with the aortic stenosis and severe mitral regurgitation. Survival with severe TR is about 64% at 1 year, and it can progress rather quickly. Historically, at least in the United States, surgery for isolated TR has been very uncommon. It's been associated with high mortality rates and morbidity, and you can see over a course of over 10 years, there are very few surgeries isolated on the tricuspid valve. One of the recent advances in this field is in the recognition that 3 grades of TR is not sufficient, and Becky Hahn and her team have really revolutionized the quantification of TR, which has been important for many of these studies. Here's a cartoon that makes the anatomy look simple. It's not really simple at all. It is most have 3 leaflets and 3 papillaries. There's some important structures nearby, like the AV node and the right coronary artery. But really, the tricuspid valve is very variable. Only about half of them have the 3 leaflet structures, and then there's a variety of different leaflet numbers and configurations. Essentially, there's 4 groups of tricuspid therapies. There's the TEER with the TriClip and the Pascal. There's annuloplasty with Cardioband. There's valve replacement, the Evoque being the most common. And then there's cable devices that include cable valves and spacers, and even the balloon that we saw yesterday, the pivot balloon that's being developed here in Korea. So I'll start with the case, 61-year-old male with posterior septal flail, torrential TR, short gap on the flail, good leaflet length, mild annular dilation. You can see really torrential TR. The choice here is going to be TEER, and this is done with a Pascal device, and it really went to trivial. Excellent result. So TEER for tricuspid regurgitation started with the old MitraClip device, and then developed into the TriClip branch of the device, and it could show consistently decent reduction, about 85% get down to moderate or less, but it doesn't obliterate all the TR, but it does improve functional class and 6-minute walk, and likewise the Pascal device, the Edwards device, has similar results. Fairly reliable reduction in TR, improved New York Heart Association class, 6-minute walk, and functional status, quality of life. So that led to the Triluminate trial that published earlier this year, looking at 350 patients, TEER with the TriClip device versus medical therapy alone, and the composite endpoint was cardiovascular death, surgery, heart failure hospitalization, and significant quality of life bump. And at 30 days, about 90% in the TEER group had less than moderate TR versus only about 5% in the observation arm. And the win ratio was 1.5, but it was almost entirely driven by quality of life. And you can see here in these graphs that those that had more substantial reduction in TR had much more improvement in quality of life. So the degree of reduction in TR correlated with the improved symptomatic relief. So is this a win? They're fairly selective in this trial, so they kept out people like those with end-stage renal disease and severe pulmonary hypertension. Do you need a sham arm? It didn't have a sham arm, so some of this placebo effect, some of this Hawthorne effect, is 1 year long enough follow-up. So a lot of unanswered questions. And although the procedure is very safe, it's expensive, and right now it doesn't have approval in the US. It has a 2B indication by the European guidelines. Here are the 1 year outcomes so far for the Pascal device, and it's similar to what we saw in the Triluminate. Improved functional status, improved quality of life, very safe, very good safety margin. So, moving to case 2, 75-year-old man, severely dilated annulus, massive TR, restricted septal leaflet. You can see massive TR here. Choice here is going to be valve replacement. Leaflets really aren't suitable for TEER. This is with an Evoke device. One thing nice about this procedure is often it's very quick, and as opposed to TEER, you get more complete and reliable reduction in TR. And here in the early data, the 1 year cohort, you get about 90% with mild or less TR. You get about up to 10% pacemaker need, so that's an important consideration. Here's the recently published 2 year data, the cohort. 1 patient went for surgery, 3 got pacemakers in this group of 30-some patients. All of them were discharged on oral anticoagulation, and despite that, about a third of them had evidence of halt on follow-up CT, those that have follow-up CTs. And this is a big concern, at least with this valve, is there seems to be a higher tendency to clot, and that can be catastrophic. Here's the TRISCEND Global Registry of 176 patients. Again, very great reduction in the TR and very high implant success, improvement in quality of life and 6-minute walk. This led to the TRISCEND 2 pivotal trial that just recently enrolled 250 patients looking at the tricuspid replacement with Evoke versus optimal medical therapy at a 2-to-1 randomization. They're going to be followed for 5 years. So this will be really important to see where this lands. So another case, 71-year-old, massive annular dilation, severe and massive TR, a large coaptation gap. Again, not good for TEER, too large of an annulus for current sizes of valve replacement. So the choice is annuloplasty. This was done with cardioband system. You can see a wire here in the right corner to make sure you don't run into the coronary with the device. These little anchors are placed in a semicircular fashion, and then they're cinched together. This is done in a TE and sometimes 4D ICE imaging. It can be very lengthy, very tedious procedure. You have to get every anchor right. Some people describe this as doing 17 triclips or mitral clips at once. And then it cinches together at the end. In this case, got a very nice reduction in the TR. Here's some of the early feasibility. You can notice that small cohort, but although there was reduction in TR, about a half were still graded in the severe or higher range. So it's even less elimination than TEER. However, over time, at least in this small group, the annulus continued to shrink, and among those that were followed longer, they sustained their reduction in TR. So it does have some durability. And it also can serve as a platform for future therapies like valve implantation. A lot of patients screen fail for these trials. In this analysis, over 40%. And most of the screen failures are anatomical. And that indicates that maybe we're treating too late. Annulus is too large, right-sided chambers are too large for these devices. And this has been a big challenge in the tricuspid world. What about surgery? The TRI-score has recently been developed as a validation tool to pick low-risk patients that can undergo tricuspid surgery. And here you can see it's based on these clinical factors, including age and right heart size and function. And this has been validated in a number of different cohorts. In this one, about 500 patients, although the overall in-hospital rate was 10%, in low-risk patients was much less than this. So surgery is emerging as a possible option in some places, like Europe and the US. Isolated tricuspid valve surgery has actually been on the rise in the last few years. One advantage of surgery is you do get more reliable reduction in TR. It can be done without cardiopulmonary arrest in some cases. So what are the unanswered questions about tricuspid valve therapies? What's the appropriate target of these trials? Is it just quality of life? Is that enough? You got to have mortality rehospitalization like you did for coapt and MitraClip. What do you need duration of anticoagulation? A lot of these patients can't take Coumadin, for instance, lifelong if they're already cirrhotic. And does TEER precludes future options like valve implantation? Should we be treating it earlier? If we treat it earlier, are we able to show an effect? We have trouble showing an effect even in sicker patients, so that's a big question. Here's an easy one. We should definitely think about being more aggressive about treating AFib and pulmonary retention and stop putting pacemakers across the tricuspid valve so we limit the number of people that are afflicted by this disease. So the future is coming. Some trials here on the way in TEER, and the Tri-STEM 2 that I mentioned, Triluminate long-term follow-up, although patients can cross over at a year. Hopefully the accumulation of this data will give us more clarity on where these therapies are. But it's a little slower than I think we thought a year or two ago, and there's obstacles in the way that could interrupt this momentum. I'll show one last case. This was a patient that got a clasp that technically went well first, and then they had an SLDA, developed recurrent severe TR, and got compassionate approval here to do a Evoke implantation over. Similar things have been done in failed MitraClips, and here the device went right in well and kind of crushed that Pascal device out of the way. Here you can see it looks like a little fly there in the heart, but it's, it actually worked pretty well. So we hope this isn't the long-term option, but occasionally you have ballot options. So in conclusion, tricuspid regurgitation portends a poor prognosis. Surgical therapy has been limited historically, but might be making a comeback. There's a lot of therapies that have changed the landscape of this field, but there's remaining questions that hopefully will be answered by clinical trials and longer-term follow-up. Thank you.
Thanks for. Yeah, I think we need to go. We have very little time and much to accomplish. So if we can go back to Dr. Makkar in Cedars, you got your gown off, so that must be a good sign, Raj. So why don't you go ahead and bring us up to date?
Okay, so Moody, can you show the pictures? So we put
absolutely.
We put another device laterally, and I have to say it wasn't easy, but you know, because there's actually a cleft. So I think Moody, go ahead and show
the struggles that we had a little bit. So we're gonna go. It was a little bit problematic because of the cleft that we had here. So we had to change the, as you can see, there's a cleft, and we had to change the orientation to make it more like 1130 and 530 to be able to grasp it to this cleft here. Otherwise, we kept losing the, and after the first grasp, you can see here the leaflet motion was still too much. We're not assured. Whenever there is a doubt, and that's a good thing about this device, whenever there's a doubt about the grasp, what we did that we were able to optimize it or open the grasp, and you can see here. So we wanted to open and see how much leaflet are inside. So we trying to optimize it here, and we're gonna open, and you can see here we are able to see the leaflets are sitting very nicely inside, and it's not moving up and down from the leaflet the device arms. So we confirmed that we had adequate and even optimized it by getting it better. And then we started to close it. And you can see here, the leaflet motion is much less than before, and the MR reduction is much less. And this is the final result here of the MR. The gradient was 5 at a heart rate of 73. And you can see the E to A ratio was reversed. This is the pulmonary veins completely normal, on right and left side. And this is how it looks like on the 3D. You can see that they're not completely parallel to each other. Again, due to the cleft that we had here and the cleft that we had here, we had to rotate it to be able to grasp this leaflet inside. And this is the 3D color. It's a very, very minor color. And we finally make the decision that it's good to be released. Just a small minor jets over there. And I'll show you the final result after release. Here, it is this one here. This is after complete release. Very, very small jets.
That's impressive.
This is a 3D, how it looks like nicely. And so it wasn't an easy repair because of the cleft.
I think because of the two clefts on
which
either
is
side.
making
And then I thought you also measured a gradient of 3, which made me right there.
So finally the gradient was 3.
That's
after release.
Yes.
So.
That's I mean that's the beauty of having a 10 centimeter square centimeter valve to start with. You can put a lot of hardware in there.
Yes, I think this wouldn't be possible, right, unless we were starting off with a 10
Yeah.
Such a large valve.
And remind me what,
All right, so
what
I
level
think
of...
the key is,
Go ahead, Raj, sorry.
no, I think the key is whether or not this will be durable, right? I think so there are times, when you have a little bit of increase in mitral regurg, when you are following these patients at a year and so on and so forth. So that remains to be seen.
What was the degree of MR after, after you let go of the second clip? Was it more than mild, or were you treating mild here for the third clip?
I
Clasp,
think
whatever.
it was mild, but I think what bothered us was that there was still a jet, and I think it was just that right now it is good, but it may not be good a week later or a month later. So
And
we
the
wanted
motion
to,
of the devices, because of that, it was a lot of redundant tissue.
and we had
It
the
was a lot-
luxury, because the gradient was 2 or 3, so we thought it's reasonable to go ahead and put another one.
Yeah, I
If
mean,
we
I think a
failed,
lot,
we could have taken it out.
I mean, I have to say, I probably would have stopped myself, but I'm maybe not so confident with putting in 3 clasps yet, but it's a really spectacular result that you got, so it's hard to argue with the outcome. It's really great. I think we're running very low on time, Raj. I want to really thank you and your team for coming on with us and sharing 2 really interesting cases. The TAVR case was terrific. The Pascal case was incredibly educational, I think, for this audience that doesn't have experience with the device, and your team did a beautiful job with the whole thing, including you, Raj. Yeah, so it's really a terrific
Thank you.
terrific to have you here with us, and thank you so much. Let's again, hope you have a great rest of the afternoon and maybe get to go home for dinner soon. For that.
Congratulations.
Okay, thank you so much. Thanks, everyone. Bye-bye.
All right, I think we will turn it over to the next panel for the next live case. Thank you so much to all the panelists and to the audience.
Thank you.